Now, we may please have Dr. Ajith S talking on the topic Induction of Labor, How, What, and When. He is the President, Kerala chapter of RCOG, additional Professor, Government Medical College, Thiruvananthapuram. Welcome, sir.
Good morning. At the outset, I would like to thank Javishan sir, the Advances team for giving me this opportunity. Respected chairpersons, seniors, dear friends. Now we'll come to a common obstetric topic. The topic that is given to me is induction of labor, how, what, and when. It's one of the very relevant topic now because in many places, more than 50% of the deliveries are now induced labor. There are a lot of concerns from the patient as well as from the obstetrician. Is it necessary to induce so much labor? So in the next few minutes, we will see the pros and cons of this induction of labor. There is no doubt that delivery should occur when the benefits are greater than the continued pregnancy. In high-risk pregnancies, often we have a consensus on the timing of delivery. For example, as discussed by Dr. Vijay in the morning, the timing of the delivery of hypertensive disorders. If there is no severe features, usually we plan to deliver by 37 weeks. If that patient is having severe features, we will try to deliver by 34 weeks or even earlier, depending upon the case. But what about the low-risk pregnancies? Have a consensus? The concern about the induction of labor near term in low-risk pregnancies is that it increases the cesarean section rate, it causes adverse perinatal and maternal outcome. But these concerns are based on some of the observational studies. But if you go through these studies, the comparator of the induction of labor is spontaneous onset of labor. In our labor room also, when a patient is coming with labor pain, there is no doubt that that patient will be delivering vaginally. But if you induce labor, that patient will be in the labor room for a long period, and the chance of cesarean section is more. But in actual clinical practice, is it a good comparator? Actually, you have to compare the labor induction with ongoing pregnancies, the expectant management, not with the spontaneous labor. So if you go through these studies, if you take such studies, even the observation studies have shown that after 39 weeks, if you continue the pregnancy, there is a more chance of cesarean section and other adverse perinatal and maternal outcome. The Cochrane review shows that there are a lot of advantages for labor induction at term, like less perinatal death, less childbirth, less babies with low Apgar score, less NICU admission, less cesarean deliveries, slightly increased operative vaginal deliveries. So then came the famous ARRIVE trial, which was published in New England Journal in August 2018. It is a multicentric randomized controlled trial. They have recruited about 6,000 nulliparous low-risk women. They compared the expectant management with the induction of labor after 39 weeks. The primary outcome they studied was the adverse perinatal outcome. Actually, statistically, there was no much difference between the continuation of pregnancy and the induction of labor. But if you again go through this, there was a 20% reduction, even though it was not statistically significant, the 20% reduction in the adverse perinatal outcome. But in the secondary outcome, what they have noted is that there is significant reduced cesarean section rate from 22.2 percentage to 18.6 percentage. Fewer hypertension. If you continue such pregnancies, more hypertension, actually 14 versus 5. If you take the women's satisfaction, again, that is improved in induction group. Another concern is, will it increase the cost? Even the cost utility analysis shows that it is a better in the induced group. So another concern is, if the patient is having an unfavorable cervix, will your induction increase the cesarean section rate? In the ARRIVE trial, about 63% had actually unfavorable cervix. Favorable Bishop score, there is no doubt that if it is favorable Bishop score, more chance of vaginal delivery. But even in the unfavorable cervix also, the induced group actually had low cesarean section compared to the continued pregnancy, the expectant management. So they have made a statement that labor induction in women with unfavorable score still resulted in fewer cesarean deliveries than expectant management. Are we medicalizing the pregnancy? Does it provide a negative experience? Is it unacceptable to the women? Again, the evidence shows that the induction at term improves the outcome, reduces the cost, and improves a woman's sense of control. So there is no doubt that after the ARRIVE trial, it changed the obstetric practices in many countries, especially in Kerala. There are more inductions happening. After publication of the ARRIVE trial, the American College of Obstetricians and Gynecologists produced a practice advisory endorsed by the Society of Maternal Fetal Medicine, stating that it is reasonable for the obstetricians and healthcare facilities to offer elective induction of labor to low-risk nulliparous women at 39 weeks. It is only after 39 weeks, not before 39 weeks. But there are a lot of criticism on this trial, concerns about the internal validity and even the external validity. Actually, it was conducted in 41 hospitals in the US. The settings there may be different in our setup. The French people started the French ARRIVE trial. It is an ongoing trial. We are expecting the results soon. It's not only the ARRIVE trial. After that, there's a publication in the AJOG 2019. Again, they compared a large number. It's a meta-analysis of the cohort studies. About 66,000 nulliparous women induced compared with about 5,84,000 women gone for a spontaneous labor. So this study also shows, this paper also shows that there is a significant benefit of considering delivering low-risk women after 39 weeks. But don't extrapolate it to the early term, 37 to 39 weeks. Don't think that after the 37 weeks, the baby is mature. Without a medical indication, if you start inducing after 37 weeks, there will be more NICU admission, more respiratory problems, and it is not advised at all. So the consensus now is, for the low-risk women, best time to deliver in low-risk women is 39 to 41 weeks. So instead of saying elective induction, we can say that now it is a risk-reducing induction, which can be considered after 39 weeks. But of course, there are some disadvantages, like longer duration in the labor room. But again, we don't have to keep the patient, all patients in the induced patients in the labor room. They can be in the room. Only when they start labor pain, they have to come to the labor room. Loss of opportunity to experience natural onset of labor, then resource intensive and costly. But again, the studies show that it is actually cheap than continuation of pregnancy. If you continue the pregnancy, actually you have to monitor these patients. So you have to do a lot of ultrasound, CTGs and all. So definitely there is a benefit for the induction of labor. But I have to say that we need to involve the women in the decision making. So if we have decided the induction, how to do induction? Almost all cases, we start with priming of the cervix. There are mechanical methods like Foley's catheter, or pharmacological methods like prostaglandin, prostaglandin E1, misoprostol, dinoprostone, PGU2, the dinoprostone insert, that is propus. When the cervix becomes favorable, we do the amniotomy. Then, after 1 to 2 hours, usually we start the oxytocin. Don't start oxytocin immediately after doing amniotomy because it can increase the amniotic fluid embolism at all. Again, when you start oxytocin, especially after having the cervix with a prostaglandin, you should be careful about the uterine tachysystole. So make sure that the prostaglandin is eliminated from the body before starting oxytocin. So if it is misoprostol is given usually 4 hours after the final dose of misoprostol, 6 to 12 hours after the dinoprostol gel, and if it is the dinoprostol insert, 30 minutes after the removal of the insert. The mechanical methods, the membrane stripping after 38 weeks is painful, uncomfortable, but properly counsel patient, we can consider it. Definitely it reduces the need for induction. Transcervical balloon catheters, actually there are expensive models, single and double balloon, but the best thing is actually the Foley's catheter. Then again, we were using laminary tent previously. The synthetic model now has come, the Dilapan S, but again it's expensive. The misoprostol, again initially there was some concern, is it a safe? Again, now the studies have shown that it is a safe and effective method of cervical priming and induction agent. The dose that is used is 25 milligram orally, 2 hourly. If you go vaginally, the problem is there's a less absorption and that will remain in the vagina for a long period. So vaginal misoprostol has to be used 4 hourly. But again, in Kerala, what the KFOG is not recommending vaginal misoprostol because there is a more chance of traumatic PPH as well as the lower segment PPH. So we recommend now only the oral misoprostol. So 25 milligram 2 hourly. Definitely it is contraindicated in patients with a previous uterine scar like a previous myomectomy or a previous cesarean section. Again, the recent RCOG scientific paper also shows that misoprostol 25 milligram 2 hourly orally is a safe method of induction of labor. The dinoprostone, again, the 2.5 ml syringe with 0.5 milligram of dinoprostone, the cerviprime gel, this has to be kept into the intracervically. Some people put it in the posterior fornix. The studies have shown that it's equally effective. Usually it is given 6 hourly, 3 doses, maximum 3 doses in 24 hours. And again, a useful method of induction of labor. It has to be kept in the refrigerator. That is very important. Then the propus, the pessary vaginal delivery system, 10 milligram dinoprostone release, about 0.3 milligram per hour. This has to be kept in the posterior fornix. And if there is any uterine tachysystole or something, immediately you can remove the insert. Quickly, the prostaglandin will be elevated. It's a very good method. It can be kept in the vagina for 24 hours. You can avoid unnecessary repeated vaginal examination at all. So once the cervix is favorable, we go for amniotomy, ARM, and then we start oxytocin. Again, the oxytocin, usually we go for the low dose regime, that is start with the 0.5 to 2 milli-international unit per ml over an infusion pump and increase it by every half to 45 minutes interval. Coming to the other methods, one method that is coming up in a big way is the mifepristone. There are a lot of studies now about the use of mifepristone. We were using it for the IUDs. Actually, now there are studies which shows that it's useful even in a time pregnancy. It has to be given 48 to 72 hours before starting the other induction methods. Relaxin, intracervical hydrolysis, limited benefit. The vaginal nitric oxide donors like isosorbate, nitroglycerin, sodium nitroprusside, All these things because of the side effects not recommended. The complementary methods, again, castor oil, nipple stimulation, sexual intercourse, herbal medicine, acupuncture, all these things are used. What is our protocol? What we usually do is we do extensive counseling of the patient before going for a risk reducing induction. It is done only after 39 weeks. The counseling starts say that if you put a Foley's catheter, don't expect delivery the next day. Foley's catheter is actually put to just to open up the cervix. We will be starting the induction next day only. So that day you can, otherwise the problem is patient is not delivering. That is the concern about the relatives. So we usually go for a slow induction. Start with the Foley's catheter. Under all aseptic precautions, you have to put the Foley's into the cervical canal, and then you have to distend it with about 30 or 60 ml. Some people even use up to 80 ml, but again, 60 ml is equally effective. And the catheter size usually we use is the 18 to 22. The one that is now normally available is a 16 or 18. Usually here we use a 18 to 22 French catheter. Then we don't usually give any antibiotic just because we put a Foley's catheter. And the next day morning at 6 o'clock we start this misoprostol, not in the night. Even if it is not expelled or anything, we don't wait for the expulsion of the Foley's catheter. It is given too early. The maximum 8 doses we give. But it's most of the patients, it is this much dose is not necessary. Most of the patients will go into labor, or the cervix become favorable. Then we do the ARM. And if the uterine contractions are not adequate, after 1 to 2 hours, we start the oxytocin. That is the usual protocol. Most of the patients deliver the next day itself. The daytime. If she is not delivering, or she is not going into labor, or the cervix has not become favorable, night usually we don't give any prostaglandin. The next day morning again we start this prostaglandin. Again, the remaining patients deliver the next day. If she is not delivering, again we don't give, we leave her in the night time, leave alone. The next day usually we do ARM and start oxytocin. So our observation is failed induction is very low with this method. And patients find it very happy also with this method. And most of the delivery occur in the daytime. That is another advantage. Again, we are collecting the data of the last 1 to 2 hours of this method of induction, and we are expecting a publication soon. So to conclude, in high-risk pregnancies, there is a consensus regarding the timing of delivery. In low-risk pregnancies also, after counseling, we can consider induction after 39 weeks. Again, that is an option that we have to give to the patient. Definitely there are some benefits for the induction. Always prime the cervix, preferably with a mechanical method prior to starting prostaglandin. Thank you very much.
Thank you, doctor.